I think the important thing to keep in mind is to date there's still been no major changes to the indications for therapy. So there's still going to be a group of patients, a large group of patients who initially are not going to require indication for treatment, and a subpopulation of those patients who may never progress to treatment. So in those cases, still the so-called watch and wait or dynamic monitoring, as we also like to call it, will apply. And I think if patients don't need the treatment, that's the best course of action. For the patients that do either initially or eventually require therapy, at the time of treatment, I think one of the important things is to know patients' options. So we talked about the patient-specific factors. Obviously, that's usually part of the regular routine visit, what their other comorbidities are, what their renal function is, those kind of things. But then on the disease-specific markers, we know that the marker testing rate, so getting FISH and IGHV, is pretty low in the United States, and recent data that Anthony Nadeau and colleagues pulled together and presented recently shows that testing rate appears to be going down in the front line. So the second part I would say for clinicians to be able to have that conversation with patients is beyond the patient sitting in front of you, is also understanding the disease. Now, these markers are not cheap, and so I don't think every patient at the time of diagnosis necessarily has to have every marker, but certainly as they're about to start treatment, the things you want to know if you're considering especially chemoimmunotherapy are what's their deletion 17p or FISH status, what's their TP53 mutation status. If there are patients that have TP53 mutations without deletion 17p, you need to do both of those tests, and then their IGHV, particularly if you're considering the chemoimmunotherapy. In terms of how to sequence from there, these can be long conversations. We aren't yet going to have a head-to-head comparing the novel agents amongst different classes, and we may never have them, although there are cooperative group studies looking at continuous duration versus fixed duration. But what I've found is with so many questions, we still encourage clinical trials, and I'd say even with all these agents, as you've brought up, we have these questions of which is the best initial therapy, which patients need multiple combinations of treatment versus which might do fine with monotherapy, and that again gets back to patient-specific and disease-specific markers. So in the education chapter book, we attempted to put together a rough flow gram, so to speak, of considerations for frontline therapy and where to sequence. But I think oncologists know their patients best, and in those conversations, consider clinical trials, make sure you really know the disease and know the patient specific factors.